Imagine your body's circulatory system, not just, pipes, but this incredibly dynamic, living plumbing system.
Yeah, totally different from the static pipes in your house, right?
Exactly. Ours pulsate, they constrict, relax, and astonishingly, they can even grow new pathways.
It's pretty amazing. So today, we're doing a deep dive into these vital pathways, the world of your blood vessels.
Right.
Our mission, really, is to unpack Chapter 19 of Human Anatomy and Physiology, the 10th edition.
Okay.
We're going to pull out the key insights, maybe some surprising facts and practical stuff about structure, function, regulation, the whole network.
Kind of like a shortcut to understanding this system that, well, keeps us alive.
You got it. Express lane to getting it.
And before we jump into the engineering of it all, maybe a quick look back.
Good idea to appreciate how far we've come.
Yeah, because for centuries, people followed Galen's idea, right? That blood just sort of ebbed and flowed like a tide.
Even in the same vessels. But then William Harvey, back in the 1620s.
Harvey. He changed everything.
Completely. His experiments showed it was a circle, a closed loop, starting and ending at the heart. Constant circulation.
A huge shift, like mapping totally new territory inside us.
Absolutely. A real paradigm shift.
So this loop Harvey described, it mainly involves 3 types of vessels.
That's the core of it. First, the arteries. Think of them as the high-pressure highways carrying blood away from the heart.
Okay, away, high pressure.
Then the capillaries. Microscopic. These are the real workhorses where all the vital exchange happens, nutrients out, waste in.
The exchange sites, got it.
And finally, the veins. These are the return routes, bringing blood back to the heart.
Arteries away, veins back, capillaries for exchange. Simple enough, but the scale.
Oh, the scale is mind-blowing.
Isn't it? If you stretched out all the blood vessels in one adult, end to end.
You'd get something like 100,000 kilometers. That's, what, 60,000 miles?
Enough to circle the Earth more than twice. It's just staggering, this vast dynamic system.
Constantly working.
So how are these vessels actually built? They're not just simple tubes, right? Let's unpack the blueprint.
Right. They have 3 distinct layers, or tunics, from the inside out.
Okay, 3 layers, starting inside.
The innermost layer is the tunica intima. The name fits it's in intimate contact with the blood.
Intimate. Nice.
It's made of this incredibly smooth lining called endothelium. Simple squamous epithelium. Its job is basically to be super slick, minimize friction.
Like Teflon for your blood vessels?
Kind of, yeah.
Yeah.
Any roughness there is bad news. In bigger vessels, there's also a thin subendothelial layer just beneath it.
Okay, slick inner lining. What's next?
Outside the intima is the tunica media. This is often the thickest layer, especially in arteries.
Thicker, okay. What's it made of?
Mostly smooth muscle cells, arranged in circles, and elastic fibers. This is the muscle layer of the vessel.
Muscle, so it can contract.
Exactly. Its activity is controlled by sympathetic nerves, the vasomotor fibers. They can trigger vasoconstriction.
Making the vessel narrower.
Right. Muscle contracts, lumen shrinks, or vasodilation.
Widening it. Muscle relaxes.
Yep. And these adjustments are crucial for controlling blood flow and pressure. It's where a lot of the dynamic action happens.
Makes sense. And the outermost layer?
That's the tunica externa, or tunica adventitia. It's mainly loosely woven collagen fibers.
Collagen for strength.
Strength, protection, anchoring the vessel to surrounding tissues, keeps it from kinking.
Okay.
And in the really large vessels, this outer layer even has its own tiny blood vessels, the vasa vasorum.
Vessels of the vessels, seriously.
Literally. They nourish the outer parts of the thick vessel wall itself, like a built-in maintenance system.
Wow. Okay, so 3 layers, each with a job. Intima for smoothness, media for control, externa for support.
You've got the basic blueprint.
Now, dealing with that pressure straight from the heart, that's the arteries' job, right? They're not all the same, are they?
Not at all. We classify them mainly by size and function. Closest to the heart are the elastic arteries, also called conducting arteries.
Elastic,
Ugh.
like the aorta.
Exactly. The aorta and its major branches, they have the thickest walls and lots of elastin. Super stretchy.
Why so stretchy?
They act as pressure reservoirs. When the heart pumps blood out, they expand, absorbing the pressure surge. Then, as the heart relaxes, they recoil elastically.
So they push the blood forward even when the heart isn't actively pumping?
Precisely. It smooths out the flow, makes it continuous, instead of just stop-start pulses.
Okay, that elasticity is key. Which brings us to, well, problems when it's lost, right? Like atherosclerosis.
Exactly. Atherosclerosis is a huge clinical issue. It's basically hardening and thickening of the arteries. That stiffening hinders the elastic recoil.
And if they can't recoil, Pressure stays high.
Right, higher pressure throughout the
Ah.
system increases the risk of aneurysms, those dangerous ballooning spots in the wall, or even a rupture.
So how does this atherosclerosis, this plaque, actually develop?
It's a process, usually starts with some kind of damage to that slick inner lining, the endothelium.
Damage from what?
Could be turbulent blood flow, chemicals from smoking, high blood pressure itself, infections. Lots of things can injure it.
Okay, step 1, injury.
Step 2, lipids, especially LDL cholesterol, start accumulating in the wall there. They get oxidized, and immune cells called macrophages gobble them up, becoming foam cells. This forms a fatty streak.
Foam cells, fatty streak. Sounds bad.
It's the beginning. Then smooth muscle cells from the tunica media migrate into the intima and proliferate, and they start laying down collagen, forming a fibrous cap over the fatty core. That's your basic plaque.
So it bulges into the lumen, the channel for blood flow.
Exactly. And then in later stages, the plaque can become unstable. Calcium salts get deposited, making it brittle, and it might rupture.
And a rupture, that can cause a clot, right, leading to heart attack or stroke.
That's the major danger. A piece breaks off or a clot forms on the ruptured surface, blocking blood flow downstream.
Scary stuff. What are the main risk factors people should be aware of, besides the obvious ones like smoking or high cholesterol?
Well, age and genetics play a role. You can't change much. Male gender is a higher risk factor until menopause. But the big modifiable ones are hypertension, smoking, diabetes, obesity, lack of exercise, stress, and diet, of course. High saturated fat, high cholesterol.
It seems like a lot of interconnected factors.
It really is. And often, chronic inflammation throughout the body is an underlying theme. People sometimes think it's just an old age thing, but the process can start quite early.
So prevention is key. But if it develops, what are the treatment options?
Lots of options now. Lifestyle changes are paramount. Medications like statins lower LDL, but also seem to have anti-inflammatory effects. Aspirin helps prevent clots.
And more invasive stuff.
Yep. Coronary bypass surgery, where they graft vessels to bypass blockages. Balloon angioplasty to squash the plaque open, often placing a stent to keep it open. And thrombolytics, clot-busting drugs for acute events.
A whole arsenal. It really highlights how vital healthy arteries are.
Absolutely.
Okay, so beyond the big elastic arteries, what's next?
We move to the muscular arteries, or distributing arteries. They're further from the heart. Their job is delivering blood to specific organs.
Distributing. Makes sense. How are they different?
They have the thickest tunica media relative to their lumen size. Lots of smooth muscle, less elastin compared to the elastic arteries. They're more active in vasoconstriction, less stretchy, more about directing flow.
Directing traffic to the organs.
Okay.
And the smallest arteries.
Those are the arterioles.
Yeah.
Often called resistance vessels.
Resistance vessels. Why is that?
Because their diameter is the main thing determining resistance to blood flow. They control blood flow into the capillary beds on a minute-to-minute basis.
So they're like the taps controlling flow to different tissues.
Exactly like taps. And tiny changes in their diameter have a huge impact on resistance. Remember that relationship. Resistance is inversely proportional to the fourth power of the radius.
Fourth power, so having the radius increases resistance
Oh.
16 times.
16 times. It's incredible leverage. That's how your body can reroute blood so effectively. Constrict arterioles here, dilate them there. It bypasses tissues or floods them with blood as needed.
That explains why smooth laminar flow is good, but turbulent flow from plaques is bad, increases resistance.
Precisely. Turbulence adds a lot of friction.
Okay, arteries handle pressure and distribution. Arterioles fine-tune flow. Where's the actual exchange happening?
That's the job of the capillaries, the microscopic, unsung heroes.
Unsung heroes, I like that. They're super thin, right?
Incredibly thin. Basically just the tunica intimus, a single layer of endothelial cells, sometimes with a flimsy basement membrane. Perfect for exchange.
Exchange of what? Everything.
Gases like oxygen and CO2, nutrients, hormones, waste products, all moving between the blood and the interstitial fluid surrounding the cells. Some have stabilizing cells called pericytes wrapped around them too.
Are all capillaries the same?
Nope. 3 main types based on how permeable they are.
Okay. Type 1.
Continuous capillaries. Least permeable, most common. Found in skin, muscles, lungs, central nervous system.
How do they limit permeability?
They have tight junctions between the endothelial cells, but usually small gaps called intercellular clefts allow limited passage of fluids and small solutes.
Except in the brain, you mentioned.
Right. In the brain, those tight junctions are really tight, forming the blood-brain barrier. Super selective about what gets through to protect the neurons. Neurons are incredibly sensitive to ischemia, any lack of blood flow.
Like a VIP security system for the brain. Makes sense. What's type 2?
Fenestrated capillaries. Fenestra means window. These have pores or fenestrations right through the endothelial cells.
Pores. Why?
Increases permeability dramatically. You find them where lots of filtration or absorption happens, kidneys, small intestine, or where hormones need to enter the blood quickly, like endocrine glands.
Built for rapid exchange.
Yeah.
Gotcha. And the most permeable.
Sinusoid capillaries or sinusoids. These are leaky, large intercellular clefts, incomplete basement membranes, big irregular lumens.
Where do you need that kind of leakiness?
Places like the liver, bone marrow, spleen, adrenal medulla. They allow large molecules, even whole cells like new blood cells, to pass through. Blood flow is slow, giving time for processing. Macrophages might even hang out in the lining, checking the blood.
Wide open highways for big cargo. Okay. Continuous fenestrated sinusoid, different jobs, different structures.
Precisely.
And these capillaries, they form networks, right? Not just single vessels.
Correct. They form interweaving networks called capillary beds. The flow through a bed, from arterial to venule, is the microcirculation.
Okay. What's inside a capillary bed?
Two main parts. There's usually a direct channel called a vascular shunt, made of a metarterial and a thoroughfare channel connecting the arterial and venule. And then branching off that are the true capillaries, the actual exchange vessels.
So blood can either go through the exchange vessels or bypass them through the shunt.
Exactly. And the body controls this beautifully using precapillary sphincters.
Sphincters, like little muscles.
Yep. Cuffs of smooth muscle at the root of each true capillary. When they contract, blood bypasses the true capillaries and goes through the shunt. When they relax, blood flows into the true capillaries for exchange with the tissue cells.
So, like, if I'm digesting food, the sphincters in my gut capillaries relax. But if I start running, maybe those constrict and the ones in my leg muscles relax.
That's a perfect example. It's all about prioritizing blood flow based on metabolic needs at that moment. Dynamic rerouting.
Clever system. Okay, so blood's done its job in the capillaries. Time to head back to the heart. That's the veins' job.
Right. The return journey via the veins. It starts with the smallest veins, the venules, which form where capillaries join up.
Venules, are they just small veins?
Pretty much. But the tiniest ones, the postcapillary venules, are still quite porous. Fluid and white blood cells can move through their walls easily, which is important during inflammation.
Okay. Then venules merge into bigger veins.
Yep. And veins have some key differences from arteries, generally thinner walls and much larger lumens or internal diameters.
Larger lumens? Does that mean they hold more blood?
A lot more. That's why they're called capacitance vessels or blood reservoirs. Up to 65% of your total blood volume can be in your veins at any given time.
65%. Where?
And that large lumen means less resistance to flow, even though the pressure in veins is much lower than in arteries.
Low pressure, though. How does blood get back up to the heart, especially from your legs, against gravity?
Great question. Veins have a crucial adaptation. Venous valves.
Valves, like in the heart.
Similar idea. They're folds of the tunica intima that prevent blood from flowing backward. They break up the column of blood, so you're not lifting the whole weight from foot to heart at once.
Ah, like locks in a canal.
Good analogy.
Oh.
You could even see them work if you let veins bulge on your hand and then try to push blood backward. A valve will stop it.
Cool. I'll try that later. Are there other special vein types?
There are venous sinuses, which are highly specialized, flattened veins with super thin walls, just endothelium really, found in places like the heart's coronary sinus and the dural sinuses, draining the brain, supported by surrounding tissue.
Okay. But sometimes those valves fail. Is that what causes varicose veins?
That's exactly it. Varicose veins are veins, usually in the legs, that have become twisted and dilated because their valves are leaky or incompetent.
So blood pools.
Blood pools, pressure builds up, the veins stretch and bulge. Factors like heredity, standing for long periods, obesity, pregnancy, things that hinder venous return can contribute.
And hemorrhoids are basically the same thing, just elsewhere.
It's essentially, yes.
Yeah.
Varicose veins in the anal region. Uncomfortable, but shows the valve principle.
It really drives home how important structure is for function.
Absolutely. And speaking of connections, let's talk anastomoses.
Anastomoses, fancy word for connections or detours.
Pretty much. Interconnections between blood vessels that provide alternative pathways or collateral circulation, like built-in detours.
Are they common?
Yes, especially arterial anastomoses around joints, in abdominal organs, the heart, and importantly, the brain. The cerebral arterial circle, or circle of Willis, at the base of the brain is a key example.
Why are they so important?
Safety net. If one artery gets blocked, blood can often still reach the tissue via an alternate route through the anastomosis. Prevents tissue death.
Like having multiple roads to a town. But some places don't have good detours.
Right. Critical areas like the retina, kidneys, and spleen have poor collateral circulation. Blockage there is much more serious.
Okay, what about other types?
There are arteriovenous anastomoses that directly connect arterioles and venules, bypassing capillaries. And venous anastomoses are super common. Veins interconnect very freely.
So blocking a vein is usually less critical than blocking an artery.
Generally, yes, because there are usually plenty of other venous routes back. You can see those networks clearly on the back of your hand.
Okay, structure covered. Let's switch gears to physiology, the dynamics. How blood flows, why, what controls it. 3 key things, right? Flow, pressure, resistance.
The core concepts. Blood flow. F is the volume of blood moving per unit time, like ml/min. For the whole body, it equals cardiac output.
Simple enough. Volume per minute.
Blood pressure, BP, is the force blood exerts on the vessel wall, measured in LME/Hg. And crucially, it's the pressure gradient, the difference in pressure between 2 points, that drives flow, high to low.
Like water flowing downhill.
Regatta.
And resistance.
Resistance is anything that opposes flow, mostly friction. We talk about peripheral resistance because most of it happens in the peripheral circulation, mainly in those arterioles we discussed.
What determines resistance?
3 main things. 1 is blood viscosity, how thick or sticky the blood is. Thicker blood, more resistance.
Okay, viscosity 2.
Total blood vessel length. The longer the total network, the more resistance, like needing more pressure to push water through a longer hose.
Makes sense. And the third, probably the most important.
Blood vessel diameter. This is the big one physiologically. Remember that fourth power relationship. Small changes in diameter, especially in arterioles, cause huge changes in resistance.
Right, the body's main way to control flow locally.
Absolutely. So the overall relationship is flow, F, is directly proportional to the pressure difference.
Okay.
And inversely proportional to resistance, air I. F
Equals delta P over R. And the key takeaway is that R, resistance, is what the body manipulates most easily.
By far. By adjusting vessel diameter, primarily arterioles, the body directs blood flow precisely where it needs to go.
Okay, so blood pressure isn't the same everywhere in that 60,000-mile network, is it?
Not even close. It's highest in the aorta, maybe 120 millimeter Hg systolic, and drops steadily all the way down to almost 0 millimeter Hg by the time it gets back to the right atrium.
And the biggest pressure drop happens where?
And the arterioles, that's where most of the resistance is encountered, so pressure plummets across them.
Right, the resistance vessels. Makes sense. So arterial pressure pulses, right?
Yep, it's pulsable. Reflects the heart's pumping. The peak pressure during contraction is systolic pressure, average around 120.
And the lowest pressure? When the heart relaxes.
That's diastolic pressure, around 70-80 millimeter Hg, maintained by the elastic recoil of those big arteries. They act like secondary pumps.
The difference between systolic and diastolic is the pulse pressure, what you feel as a pulse.
Exactly. And the average pressure that actually drives blood flow to the tissues is the mean arterial pressure, MAP.
How do you figure that out? It's not just the average, is it?
No, because the heart spends more time in diastole. MAP is roughly diastolic pressure plus 1/3 of the pulse pressure. For 12 to 80, pulse pressure is 40, so MAP is 80 plus 1340, about 93 millimeter Hg.
Okay, 93 millimeter Hg. And both MAP and pulse pressure decrease the further you get from the heart.
They do. The pressure wave dampens out.
And doctors use these numbers, pulse, BP, as vital signs, right? To check how things are working.
Absolutely. Taking a pulse at the radial artery, carotid, etc., gives heart rate and rhythm. Those points can also be pressure points to control bleeding.
And measuring BP with the cuff, the sphygmomanometer.
Yep, the auscultatory method. Inflate the cuff on the brachial artery, then listen with a stethoscope as you release pressure. The first tapping sounds, Korotkov sounds, are systolic pressure. When the sounds disappear, that's diastolic.
Standard procedure. Now, by the time blood gets to the capillaries, pressure is way down.
Way down. Drops from about 35 millimeter Hg entering to maybe 17 millimeter Hg leaving.
Why so low?
2 reasons. Capillaries are fragile. High pressure would burst them. And low pressure allows time for exchange and favors filtration of fluid out into the tissues.
Okay. And in the veins, even lower.
Much lower and steady. Only about a 15 millimeter Hg difference driving blood from venules back to the heart. Very low pressure gradient.
Which explains why a cut vein oozes, but a cut artery spurts.
Exactly. Pressure difference.
So how does blood get back with such low pressure against gravity? We mentioned valves, but what else helps?
3 main mechanisms for venous return. Number 1 is the muscular pump.
Leg muscles squeezing the veins.
You got it. Contracting skeletal muscles, especially in the limbs, compress the deep veins, milking blood upward. The valves prevent backflow. That's why moving around helps prevent pooling if you stand or sit a lot.
Makes sense. What else?
The respiratory pump. When you inhale, pressure decreases in your chest and increases in your abdomen. This pressure difference helps suck and squeeze blood upward toward the heart.
Breathing helps pump blood.
Cool. And third, sympathetic venoconstriction. Sympathetic nerves can cause veins to constrict slightly. Since they hold so much blood, even mild constriction reduces their volume and pushes blood toward the heart, increasing venous return.
Muscle pump, respiratory pump, venoconstriction, all working together.
All helping overcome that low pressure gradient.
Okay, so maintaining blood pressure seems incredibly complex. It depends on cardiac output, resistance, blood volume. How does the body regulate it all?
It's a constant balancing act. We have short-term controls, mostly neural and hormonal, for rapid adjustments, and long-term controls, mainly the kidneys regulating blood volume.
Short-term neural. Where does that happen? Brainstem.
Primarily the cardiovascular center and the medulla oblongata. It has cardiac centers controlling heart rate and contractility, and the vasomotor center.
Vasomotor center controls vessel diameter.
Right. It sends out signals via sympathetic nerves that maintain a baseline level of moderate constriction in arterioles, called vasomotor tone. Then it adjusts that tone up or down.
How does it know what adjustments to make?
Through reflexes. The most important are the baroreceptor reflexes.
Baro meaning pressure sensors.
Exactly. Mechanoreceptors, sensitive to stretch, located in the carotid sinuses, monitoring blood flow to the brain, and the aortic arch, monitoring systemic BP.
What happens when BP rises?
They get stretched. Fire more impulses to the cardiovascular center. This inhibits the vasomotor center, causing vasodilation, and stimulates the cardioinhibitory center, slowing the heart. Result, BP drops back down.
And if BP falls?
The opposite. Less stretch, fewer impulses. Vasomotor center increases tone, vasoconstriction. Cardioacceleratory center speeds up the heart. BP rises.
Quick response system. Does it work long term?
It adapts.
Yeah.
If you have chronic high blood pressure, the baroreceptors essentially reset to that higher level. So they're great for short-term fluctuations, like standing up.
Ah, that explains orthostatic hypotension sometimes. That dizziness when you stand up fast.
Could be a factor, yeah. Sympathetic response, lagging a bit.
Okay, baroreceptors. Any other reflexes?
Chambermator reflexes. These respond to changes in blood chemistry, low O2, high CO2, high acidity, H+.
What do they do for BP?
They stimulate the cardioacceleratory and vasomotor centers, increasing cardiac output and vasoconstriction to speed up blood flow, mainly to the lungs to fix the chemical imbalance. They play a bigger role in respiration, though.
And our brain, like thoughts and emotions, can affect BP too, fight or flight.
Definitely. Higher brain centers like the cerebral cortex and hypothalamus can influence the medullary centers. Stress, fear, exercise all impact BP via these pathways.
Okay, that's neural. What about short-term hormonal controls?
Several hormones jump in. During stress, the adrenal and medulla pumps out epinephrine and norepinephrine.
Adrenaline rush.
Yep. Increases heart rate, contractility, and causes widespread vasoconstriction, except in heart and skeletal muscle, boosting BP.
What else?
Angiotensin II, generated when BP or blood volume is low, triggered by renin from the kidneys. It's a potent vasoconstrictor.
Angiotensin II sounds important.
Very. It also stimulates aldosterone and ADH release, further boosting volume and pressure. We'll come back to it.
Okay. Any hormones that lower BP?
Atrial natriuretic peptide, ANP. Released by the heart's atria when stretched by high blood volume pressure, it promotes sodium and water excretion by the kidneys, lowering volume, and causes vasodilation. Lowers BP.
Heart makes a hormone to lower pressure. Interesting. And ADH?
Antidiuretic hormone, ADH, or vasopressin, made by the hypothalamus, released by the pituitary. Main job is water conservation by the kidneys. But in cases of severe hemorrhage, really low BP, it's released in high amounts and acts as a powerful vasoconstrictor, hence the name vasopressin.
Trying to clamp everything down. Got it. So those are the short-term fixes. What about the long game?
The long-term renal mechanisms. The kidneys are the ultimate regulators of blood pressure because they control blood volume.
How do they do that directly?
Through the direct renal mechanism. It's simple physics, really. If BP is high, more fluid filters out of the blood into the kidney tubules, producing more urine. Blood volume decreases, BP decreases.
And if BP is low?
Less filtration, kidneys conserve water, urine output drops, blood volume increases, BP increases. It's automatic, independent of hormones.
Simple but effective. Is there an indirect way too?
Yes, the indirect renal mechanism, which involves that renin-angiotensin-aldosterone system we mentioned.
Ah, renin and angiotensin II again.
Right. When arterial BP drops, kidney cells release the enzyme renin. Renin kicks off a cascade that produces angiotensin II.
And angiotensin II does what again?
4 key things to raise BP. 1. Stimulates the adrenal cortex to secrete aldosterone, which makes kidneys reabsorb more sodium, and water follows. 2. Makes the posterior pituitary release more ADH, increasing water reabsorption. 3. Triggers the thirst sensation in your brain, making you drink more. 4. Is a potent vasoconstrictor itself.
Wow, a multi-pronged attack to raise blood pressure and volume.
It's a powerful system for long-term BP regulation.
Makes sense why drugs targeting this system, like ACE inhibitors, are used for high blood pressure.
Exactly, they interrupt this cascade.
Okay, so regulation is complex, but what happens when it goes wrong? Homeostatic imbalances, like hypertension, high blood pressure.
Right. Chronically elevated BP, usually defined as over 490 millimeter Hg. It's often called the silent killer.
Why silent?
Because it's often asymptomatic for years, maybe decades. But silently, it's damaging blood vessels, straining the heart, accelerating atherosclerosis.
Leading to serious problems down the road.
Heart failure, stroke, kidney failure, vascular disease. Major consequences.
Is there usually a clear cause?
In about 90% of cases, no single cause can be identified. That's primary or essential hypertension. It seems to be a mix of genetics and lifestyle factors.
Like what?
Heredity plays a role. Diet high in salt, fat, cholesterol,
Mm.
obesity, age risk increases after 40, diabetes, stress, smoking, lack of exercise.
Many factors we can actually influence, though.
Absolutely. That's why lifestyle changes are the first line of treatment. Diet, exercise, weight loss, quitting smoking, managing stress. Plus, there are effective medications, diuretics, beta blockers, calcium channel blockers, ACE inhibitors, ARBs.
So it's controllable, even if not curable.
Highly controllable for most people. The other 10% is secondary hypertension, where there is an identifiable cause, like kidney disease, artery obstruction, or an endocrine disorder like Cushing's or hyperthyroidism. Treat the cause, BP often normalizes.
Okay, high BP is bad. What about low BP, hypotension?
Usually defined as below 90-60 millimeter Hg. Generally, it's not a concern, might even be associated with longevity.
But sometimes it can be a problem, like that dizziness standing up.
Right, orthostatic hypotension. Temporary drop, common in elderly. Chronic hypotension might signal underlying issues like Addison's disease or malnutrition, but the really dangerous one is acute hypotension.
Acute low BP, sign of shock.
Precisely, a key indicator of circulatory shock.
What exactly is circulatory shock?
It's a critical condition where blood vessels aren't adequately filled and blood can't circulate normally. Tissue perfusion fails, cells start dying from lack of oxygen, life-threatening.
What causes it?
Several types. Most common is hypovolemic shock, low volume, results from massive blood or fluid loss, hemorrhage, severe burns, vomiting, diarrhea.
Body just doesn't have enough fluid volume. What are the signs?
Weak, rapid pulse, thready, cool, clammy skin due to intense vasoconstriction as the body tries to compensate. Treatment is fluid replacement fast.
Okay, low volume shock, other types.
Vascular shock. Here, blood volume is normal, but circulation is poor because of extreme vasodilation. The pipes are just too wide open, so pressure plummets.
What causes that extreme vasodilation?
Things like anaphylaxis, massive histamine release, failure of the autonomic nervous system, neurogenic shock, or severe systemic infection. Septic shock, often from bacterial toxins.
And the third type?
Cardiogenic shock. This is pump failure. The heart itself is so inefficient it can't sustain adequate circulation. Often follows multiple heart attacks.
Hypovolemic, vascular, cardiogenic, all dire situations.
Absolutely. Require immediate medical attention.
Okay, we've talked overall pressure. But how does the body ensure the right amount of blood flows to specific tissues when needed? Tissue perfusion.
Right. Tissue perfusion is about delivering the right flow rate for each tissue's specific needs. O2 delivery, waste removal, gas exchange in lungs, nutrient absorption in gut, urine formation in kidneys.
How is it controlled, both system-wide and locally?
Both. Extrinsic controls the nervous system, sympathetic, and hormones maintain the overall MAP and can redistribute blood flow on a larger scale, like during exercise, shunting blood away from gut kidneys towards muscles.
And intrinsic, local control.
That's autoregulation. Organs controlling their own blood flow by adjusting the diameter of their arterioles locally, independent of systemic nerves or hormones. It's quite amazing.
How do they do that? What signals them?
2 main ways. Metabolic controls. Tissues signal their needs. If a tissue is active, O2 levels drop, and metabolic byproducts like CO2, making H+, K+, endosine, lactic acid accumulate. These act as signals.
Signals for what?
Vasodilation. They tell the local arterioles to open up, bring more blood. Especially important is nitric oxide, NO, a powerful vasodilator released by endothelial cells in response to these signals. There are also vasoconstrictors like endothelins. The balance is key. Inflammatory chemicals also cause vasodilation.
So the tissue basically orders more blood when it's working hard.
Mm.
Clever. What's the other way?
Myogenic controls. Myo for muscle, the agenic for origin. The smooth muscle in arterial walls responds directly to stretch. If blood pressure rises and stretches the vessel wall, the smooth muscle automatically contracts vasoconstriction to protect downstream capillaries from excessive pressure. If pressure falls and stretch decreases, the muscle relaxes vasodilation to ensure adequate flow. It helps keep tissue perfusion constant despite fluctuations in systemic BP.
Metabolic and myogenic, local smarts. Does the body ever build new vessels if needed long-term?
It does. That's long-term autoregulation or angiogenesis. If short-term methods aren't enough, over weeks or months, new blood vessels can grow and existing ones enlarge. Common in the heart if a coronary artery is partially blocked, or in people adapting to high altitude.
Building new roads when traffic is consistently high. Amazing. Does this autoregulation work the same everywhere?
Mostly, but some organs have unique twists. Skeletal muscle is a great example. During exercise, blood flow can increase enormously active hyperemia. The local metabolic signals, low O2, high metabolites, completely override the systemic sympathetic vasoconstriction signals. Muscle needs trump everything else.
Makes sense for exercise. What about the brain?
Brain blood flow is kept remarkably constant, about 750 millimol. Neurons hate ischemia. It's tightly autoregulated, mainly by CO2 levels, via pH changes and myogenic mechanisms. If MBP drops below 60, you might faint. If it goes above 160, you risk cerebral edema. Tight control.
Skin.
Skin flow is mostly about temperature regulation. It can vary hugely, from 50 to 2,500 millimeter. Controlled by sympathetic nerves adjusting arterial diameter and flow through special arteriovenous shunts. Heat causes vasodilation, flushing, to radiate heat. Cold causes vasoconstriction, paleness, to conserve it.
Lungs. Heard they're different.
Lungs are unique. In the pulmonary circulation, low oxygen causes vasoconstriction, high oxygen causes vasodilation. Opposite of systemic circulation.
Why the opposite?
It matches blood flow to airflow. Blood gets shunted away from poorly ventilated low oxygen areas of the lung and directed towards well-ventilated high oxygen areas. Maximizes gas exchange efficiency.
Clever. And the heart itself. Coronary circulation.
Heart muscle gets its blood mainly during diastole, when the ventricles are relaxed, because contraction compresses the coronary vessels. During exercise, coronary vessels dilate hugely, mainly due to metabolic signals like adenosine, increasing flow 3 to 4 times. It has to, because even at rest, the heart extracts about 65% of the oxygen delivered. Increased demand needs massively increased flow.
Okay, wow, that covers the intricate controls. Let's finally map out the pathways. 2 main circuits, right? Pulmonary and systemic.
Exactly. Pulmonary circulation is the short loop. Right ventricle, pulmonary trunk, pulmonary arteries, lungs, gas exchange, pulmonary veins, left atrium. Its sole job is oxygenating blood.
And remember, pulmonary arteries carry deoxygenated blood. Pulmonary veins carry oxygenated blood, opposite of the rest of the body.
Key distinction. Then the systemic circulation is the long loop. Left ventricle aorta, branching arteries, capillaries in all body tissues, veins, venae cavae, right atrium. This provides the functional blood supply everywhere else.
When we look at diagrams, systemic arteries are red, veins blue. But structurally, what are the main differences in their layout?
A few key things. Depth. Arteries usually run deep, protected. Veins have both deep routes, often alongside arteries, and superficial routes just under the skin.
Like the ones you see on your arm.
Exactly. Interconnections. Venous pathways are much more interconnected, lots of anastomosis. Arterial pathways are less redundant, usually.
And unique drainage. The brain uses those dural venous sinuses, not typical veins, and digestive organs drain via that special hepatic portal system.
Right, not directly into the main vena cava initially.
Okay, let's briefly trace the main highways. Systemic arteries all start from the aorta, right?
The biggest artery leaves the left ventricle. First part is the ascending aorta, giving off the coronary arteries to the heart muscle itself.
Then the curve, the aortic arch.
Gives off 3 big branches for the head, neck, and upper limbs. Brachycephalic trunk splits into right common carotid and right subclavian, then left common carotid, then left subclavian.
Carotids for head necks, subclavians for arms.
Got it. Then it goes down. Yep. Becomes the descending aorta, runs along the spine. The part in the chest is the thoracic aorta, supplying thorax walls, esophagus, bronchi. Below the diaphragm, it's the abdominal aorta.
Supplying all the abdominal organs.
Pretty much. Big branches like the celiac trunk for stomach, spleen, liver. Superior mesenteric, small intestine, part of large, inferior mesenteric, rest of large intestine, plus paired arteries to kidneys, renal, gonads, etc.
Finally, it splits.
At the bottom of the abdomen, it splits into the right and left common iliac arteries, which then supply the pelvis and legs.
So head and neck arteries include those carotids, which have important sensors, right? Carotid, sinus, and body.
He has baroreceptors and chemoreceptors there. The carotids split into internal to brain and external face scalp. And the cerebral arterial circle of Willis, at the brain's base, is that vital anastomosis ensuring brain blood supply.
Upper limbs. Subclavian becomes axillary, armpit. Then brachial, upper arm, pulse point, splits into radial and ulnar forearm, forming arches in the hand. Simple enough path.
Follows the bones, pretty much.
Abdomen, we mentioned celiac, mesenterics. Legs. Common iliac splits into internal pelvis and external iliac. External becomes the femoral artery, thigh.
Big one, pulse point in the groin. Gives off deep branches.
Then popliteal, behind knee, splits into anterior and posterior tibial arteries, lower leg. Anterior tibial becomes dorsalis pedis, on top of the foot, another key pulse point. Posterior tibial supplies the sole.
That covers the main arterial routes. A complex but logical branching pattern.
Now, the return trip. Principal veins, draining into the two big ones.
The superior vena cava, SVC, and inferior vena cava, IVC. SVC drains everything above the diaphragm, it's a part wall, formed by the union of the two brachiocephalic veins, which collect from head, neck, arms.
And the IVC.
Drains everything below the diaphragm, widest vessel in the body. Formed by the common iliac veins joining, runs up alongside the abdominal aorta.
Head and neck drainage, besides the jugulars.
Main ones are external jugulars,
Yeah.
superficial, internal jugulars, deep, drain brain via those dural venous sinuses, and vertebral veins. Internal jugulars are the big drains for the brain.
Upper limbs, deep veins follow arteries, radial, ulnar, brachial, etc. Superficial ones are important too.
Very. The cephalic, lateral, and basilic medial veins are prominent, connected at the elbow by the median cubital vein, the prime spot for blood draws.
Ah, the familiar one. And the thorax has that azygos system.
Yes, the zygosystem is a network draining the chest wall, acting as a collateral pathway if the vena cavae are obstructed. Complex, but important.
Abdomen. Veins generally follow arteries, renal, gonadal, etc., draining into the IVC.
Except the digestive organs. Stomach, intestines, spleen, pancreas drain into the hepatic portal system.
Explain that again. Portal system means two capillary beds.
Exactly. Blood from digestive capillaries, nutrient-rich, maybe toxin-laden, collects in veins, superior mesenteric, splenic, inferior mesenteric, that merge into the hepatic portal vein. This vein goes not to the IVC, but directly to the liver.
And enters a second capillary bed in the liver.
The liver sinusoids. Here, the liver processes nutrients, stores glucose, makes proteins, detoxifies substances, removes bacteria. After processing, blood collects in the hepatic veins, which then drain into the IVC.
So the liver gets first crack at everything absorbed from the gut. Vital filtering step.
Absolutely crucial.
Pelvis and lower limbs. Deep veins follow arteries, tibials, popliteal, femoral, iliacs. Superficial ones?
The great saphenous vein is the main one. Longest vein in the body, runs up the medial side of the leg, often harvested for coronary bypass grafts, and the small saphenous vein on the posterior calf. Both arise from foot veins.
Okay, that maps the main routes. Lastly, how do these vessels develop and change with age?
Embryonically, they arise from mesoderm, endothelial lining from blood islands, outer coats from surrounding mesenchyme. Vessel growth often follows nerves.
And fetal circulation is different, right? Bypasses.
Yep. Special vessels like the umbilical vein, bringing oxygenated blood from placenta, and arteries, returning waste. Shunts like the ductus venosus bypass the liver mostly. These normally close up shortly after birth when the baby breathes and placental circulation stops.
What about aging? Vessels hold up well.
They're pretty robust, but age brings changes. Valves and veins can weaken, varicose veins. Atherosclerosis, as we discussed, is a major age-related issue, though lifestyle is huge. Estrogen protects women somewhat pre-menopause.
And BP tends to rise with age.
Generally, yes. Systolic pressure rises throughout life. Risk of hypertension increases significantly after 40.
But lifestyle matters more than just age itself.
Often, yes. Poor diet, lack of exercise, smoking can accelerate vascular damage far more than chronological aging alone. Lifestyle choices are profoundly important for cardiovascular health throughout life.
It really comes back to that. This intricate, dynamic system. It responds to how we treat it.
Day in, day out.
So thinking about all this adaptability, this complex regulation, It really makes you wonder, doesn't it? How much of our cardiovascular health is truly just genetics, predetermined, and how much is actually down to the choices we make every single day?
That's the provocative thought, isn't it? Genetics loads the gun, but lifestyle often pulls the trigger. Understanding this system hopefully gives everyone a bit more power over those daily choices.
Absolutely. We hope this deep dive has sparked some curiosity and encourages everyone to keep exploring the amazing machine that is the human body.
It truly is remarkable.
Thank you, everyone, for being part of our last-minute lecture family.